Yes, so I wanted to do some brief introductions to other panelists who are here. Professor Joseph Shemesh is director of the Shabbat Medical Screening Center in Israel, has 30-year experience with coronary calcium. He actually has a few slides, but with the time limit we've talked about, we have another session tomorrow morning where we're going to talk more around coronary calcium and CT scanning. So he'll generously contribute some of his further slides on that. We have, let's see, make sure I've got all my, we have Dr. Nathan Wong, who I've had the privilege to work with recently with Mort around analyzing a number of the MESA data and applying AI technology. He's a professor of medicine at UC Irvine and directs their heart disease prevention program. And then last but not least, good friend, longtime colleague, Dr. Zahi Fayad, who's here at Mount Sinai, who's professor of both radiology and medicine, cardiology, also directs the Biomedical Engineering and Imaging Institute. Has the classic image of, I think, the first MRI scan of a vulnerable plaque in your LAD, and has been a pioneer in molecular imaging and very early in imaging inflammation in atherosclerosis, very much around highlighting that it's a biologically active disease. The New York Times still just had a thing that, you need to lower cholesterol because there's this sort of stuff that builds up in your heart arteries. No acknowledgement that it's this active, biologically active disease that can, as the first case, the 50-year-old example, can strike people out of the blue if we're not looking for it and not treating and preventing it. So why don't you start off, maybe think about what, so we'll do a few questions here and then open up to the audience.
Yeah, and I know that we're supposed to break at 11:30. We're way over. Do you think we can encroach a little on the, yes, thank you. So many questions have come up, I think, in all of our minds listening to these excellent presentations in this session. Related to the question I asked from the mic before is there enough evidence to act on the early detection of disease? And I'd like to start, say, with Dr. Sharma, who's sitting closest. Do you think that CT detection of aortic valve calcification should trigger a workup for aortic stenosis? And is it a certain threshold of coronary calcium? Do you see patients who have been detected on the basis of CT?
Yeah, so question is from the valve point of view, we see the kind of young patient, or for screening point, which is more and more patients are coming to the cath lab. They're bypassing the stress test or echo. They're getting CTA, high calcium score, or some disease, and they come to the cath lab. So that is for coronary artery disease. But for the valve intervention, for valvular point of view, they will mention if there is a calcium present. Usually in that you expect the valve is not narrow, maybe thickened, but calcium. But yeah, there is a criteria for high calcium versus low calcium on the valve. 1200 for female and 2000 for male will be high calcium, but that basically means it's a severe. But if there is some calcium, besides the coronary calcium, and I have not seen any patient who had only the valve calcium and there was nothing in the coronary. So once you have the valve calcium, you always will have some calcium in the coronary arteries. But yeah, if some calcium in the aortic valve, which will trigger the next test, and test will be echocardiogram. So you do not diagnose truly the aortic stenosis by the CT. It's the echo will tell us in terms of the gradient, the pressure gradient, the velocity, and so on and so forth, and of course, ejection fraction will make it. So question comes back, how can we do early detection? If the CT gives us some calcium on the valve, I would say yes. Let's go to the echo path, and after that, of course, besides the clinical examination, and then go further and follow the patient based on degree of stenosis or regurgitation.
Mort, you can probably many of you can answer this question. I think for men, a calcium score in the aortic valve of 3,000?
2,000.
Is it 2,000? 2,000? Yeah. And for women, 1,200?
1,200, yeah.
Okay. So that should suggest the presence of severe aortic stenosis and trigger referral to the echo lab.
But you're suggesting even lower than that. This structure is very severe.
Yeah.
So the question is, can we lower the threshold? And do you see benefit in those people that have lower calcium? Go for the next step for a workup. Do you see that? We don't have a trial, like David said, but do you see as an expert benefit in triggering a care pathway?
Yeah. So the question comes, you have detected the mild, let's say aortic stenosis by echocardiogram or by CT. So question is, what can you do? And that's where the buck stops. We do not have any treatment or good treatment upstream to halt this disease progression. There have been trials of the statins, and they have been with the mixed results, but overall message is it does not work. One study showed yes, but overall, and there is no other treatment. Now, any of the anti-inflammatory will have this benefit, it still need to be seen. But what it will trigger is that you are not missing that moderate to severe AS, which patient comes one day syncopized and in shock. So that will just trigger that by testing, you went back to the early stage and follow up with the 6-month or yearly echo to follow the patients till the natural history of the disease.
So you think the value might be in monitoring?
Yes.
The disease, not any intervention.
I think just in line with what Dr. Sharma said, I think we're evolving at the moment. At this TCT, as you heard, early TAVR will be presented. These are asymptomatic, mild to asymptomatic patients with aortic stenosis. So this could maybe change that, that threshold of calcification to even lower. Because if there's benefit early on, as Dr. Sharma described, maybe they're sitting in this curve of not just diving yet, but in this curve, they're damaging the heart muscle, everything else, and that an earlier intervention with a valve, then I think will change the needle. But I think more interesting would be to better understand, are there therapies? I mean, we know there's some relationship between Lp(a) and aortic stenosis. There's trials going on. They're investigator initiated just to see where it is. With pelacarsen, I know there is going on, and now there are other, Merck and others are also, and Amgen are looking at Lp(a) therapies, even in this earlier calcific aortic stenosis. No one really understands, but I do think that this needle is moving.
Thanks so much. Dr. Shemesh, you've had a long experience with coronary calcium. It's one of the areas that still is this question, as David raised early on, in terms of data and outcomes in randomized trials. So how do we use the evidence that we have now to guide us, and what additional studies do we potentially need?
Yes, I think we are there. I think we are there. It is in the guidelines. I think for this form, the most important thing is that calcium score can be evaluated by each non-cardiac chest CT. And this is a lot of information that can get there. And this is very important. I have a very important comment on coronary atherosclerosis. Coronary atherosclerosis is not risk factor disease. It is a genetic disease. You have two brothers. I have a lot of them. One with a wonderful, healthy lifestyle. And the other, just on the other side, smoking and everything, and he has 0 score, and the other has a lot of calcium. Secondly, everybody who sit here have already plaque in his coronaries. It's come from the IVU study on transplanted heart that show us that the teenagers, 1 of 6, already have signs of atherosclerosis, and the transplanted healthy heart in 50 years, all of them has signs, but everybody his own rate of acceleration of the atherosclerosis. Some died on the age of 100 and they have nothing as they had on 10 years. And some have on the 40s, 50, they are plan of atherosclerosis. So the future is to look at these genes and to, I think so, and maybe the most important, to find the protecting factors, not only the risk factors.
I wanted to get Dr. Fayad to follow up on that, given you've been imaging atherosclerosis across the lifespan, and also, you know, are there opportunities from low-dose CT to look at additional information beyond the calcification? There's sort of pericoronary fat and other things that may give more around the biologic activity and risk for progression.
Yeah, so that's very true. The aspect of the data coming from P-Day, the development of atherosclerosis, Nathan knows this very well in terms of its development. So this is something that occurs early on. And there's obviously something that we're not talking, you just mentioned, the molecular activity. You know, inflammation is one of them, but there are also opportunities for other signatures. So right now, I think with the low dose imaging that we have, will be hard to get molecular activity, you know, from these images, but they could be other surrogate markers that we still have to validate. One of them, as you mentioned, is a coronary peri-artery fat accumulation. That's not a direct measure of inflammation, but it could be an indirect measure. I think there is an opportunity to look at that. But I also think that, you know, beyond, I mean, although I'm an imager, but I'm also looking at other markers beyond imaging. There are things in the blood, and especially in the future, we may be able to measure point of care, measurement of blood in a frequent manner, and then, you know, it's getting cheaper to analyze a lot of these proteins. So we could come up with a signature that is a combination of imaging as well as other markers. And then the third one is the aspect of physiology and using, as you know very well, wearables and other type of sensors to put them all in combination. I mean, more and more, I'm starting to, you know, rethink of my origin, which is in electrical engineering, that it's very hard to rely on just one marker to try to diagnose a problem when you're looking at a computer board and you're trying to figure out, is this working? What is the issue with this? You need a combination of markers. And I think, Vivek, you alluded to in some of the remote patient monitoring aspect. You mentioned the looking at voice, which is another one. And I know Mort presented a very beautiful concept, which is that combination of things. So I would like to take the discussion beyond the imaging.
There's so many things to discuss. I don't want to take it away from imaging for a moment. And I'd like Nathan Wong and others who would like to chime in to talk about the impact of the patient seeing their disease, and in the case of coronary calcium, seeing calcified plaque, and what the impact can be in terms of patient adherence, persistence, motivation.
Yeah, that's a wonderful question, David. And I also want to get back to your original question about, you know, are we there yet and do we need a randomized trial? But yeah, with respect to the question of, you know, is a picture worth 1,000 words, right? So we published one of the original studies looking at this with coronary calcium back in 1996. So like 28 years ago, I guess it was. So what we showed, and this was based on a cohort of people that got coronary calcium scanning in the Los Angeles area when they had these Heart Check America screening programs, you know, that some of you may remember from the late 80s and early 90s. But what we showed was that we surveyed people who got calcium scans, and those who were scanned, and particularly if their scores were higher, were shown to be reported that were more likely to like follow a healthy diet, start cholesterol lowering medicine, see their doctor even, as well as other preventive behaviors. And then you may also recall the Eisner study that Dan Berman and I were involved with, and that was actually the first randomized trial of calcium scanning versus no scanning that also showed not only improved behaviors, but it showed that people who got scanned actually halted their progression in Framingham risk score, whereas the people who were not scanned actually had an increase in score. But that study being done in the fairly healthy Beverly Hills type population around Cedars-Sinai didn't have enough events to show that event prediction was important. So, you know, kind of back to your question, and, you know, I think we've all been concerned that the Preventive Health Services Task Force is really insistent on randomized trials. You know, of course, there's since the Eisner trial, there's the Dan Canvas trial, which was published a few years ago, which dismissed its primary endpoint, which actually they looked at total mortality, and most of us feel that they should have looked at you know, like MACE, you know, and all cardiovascular events. And they recently did a secondary analysis looking at what they call patient, you know, patient preferred outcomes, and where they surveyed patients about what outcomes they felt were most important. So the patients felt that, you know, like the usual MACE outcomes, MI, stroke, and cardiovascular death were most important. And when you looked at that composite, there actually was a significant benefit. But we're still waiting, of course, for the for the Robinska trial that's going to be most definitive in showing whether calcium scanning improves outcomes over the long term. So
Dan Canvas published too early. Their primary endpoint is called for at 10 years. They published too early and blew it. Roxana, when you see patients, do you show them images?
Yes, I pull it up. It's really, I learned that from Vivek Reddy, because when he I was lucky enough to be in Vivek's clinic, because that we shared clinic space, and I saw that every EP patient is seeing what atrial fibrillation looks like, what is it doing, what's going on with the pathways. He shows these beautiful cartoons. And so now I do the same. And then I show them, and here's what the CAT scan does, and here's what yours looks like. And it does make a difference. And I don't know that what the unknowns and the intangibles are the change in behavior and how that has an impact on not just adherence, but actual change in the biology. We don't understand that at all. And it's really exciting to see.
I wanted to follow up with Dr. Reddy. We had a little bit of email conversation in advance, and I know you indicated it in your talk, but this idea that Mort originally showed of, you know, looking at any one characteristic, and to Dr. Fayad's point, we have multiple sources of data. The concept of looking at the underlying sort of vulnerable structure with large atria that you can see on a low-dose CT, in combination with, do they have a vulnerable characteristic of their rhythm and an underlying vulnerable patient with CHA2DS2-VASc scores and things like that. So yeah, how do you see us moving forward on really, how do we optimize that early detection, but who's really going to benefit from the intervention, which is what we're, you know, at the end of the day, what we most care about.
Yeah, I'm going to be a little redundant. I apologize for that. But About a decade ago, we thought that just identifying AFib was sufficient and would improve outcomes. And what we rapidly learned was no, we can identify AFib, but what happens is that, in fact, if you just did a study where we took anybody walking on the street and you randomized them to giving an oral anticoagulant versus not, if you did a big enough study, say 1 billion patients, you would see a reduction in stroke probably. The problem is you pay two penalties, two costs. One is the cost of bleeding, which is a substantial one, and we know from the coronary studies and other studies that bleeding means death. And the second cost is actually cost itself. I mean, these are expensive therapies, and there's a cost analysis that becomes critical. So in the past, we've really just looked at clinical predictors and the CHAS-VASc score, for example, or I should say clinical risk predictors of morbidity, plus whether or not there's AFib and maybe how much there AFib that there is. Now it's very clear that we need at least one and probably multiple other dimensions, whether that's an imaging dimension, a functional dimension, a humoral biomarker dimension. And the complexity here is that we're talking about improving outcomes in where we're talking about potentially treating a lot of patients. So there's both the cost and the complexity of whatever that third dimension is. So it could be a fantastic test, but if it costs a lot of money to do the test and it's hard to implement in practice, it's not going to change outcomes on a population level. And then, so I think that's where the complexity is. I sort of alluded to a little bit, there's, I think, some optimism to think that, and sorry, there's one last issue, which is then implementing this in clinical practice, right? Just the CHADS-VASc score, which is not a particularly complex score, is very hard to implement that in clinical practice. So how do you take something that's somewhat complicated, add additional complexity, and incorporate in clinical practice? And I think that what we're probably moving toward is something where there's some deep learning algorithm that'll help us, collate the clinical information, scan through probably the EHR, and hopefully come to saying this is a high risk person that'll benefit from OAC or not. But ultimately, and this is my last point, we have to do prospective randomized trials. If we don't see improvements in outcome, it just is not going to affect practice.
Yeah, and then as Bob Harrington mentioned, there has to be some financial incentive to actually implement, what we learn. Dr. Pinney, I think there's similar challenges and concepts around heart failure. There's data from the CT scans that are looking at chamber dimensions can be predictive of heart failure. It's now been added, our prevent risk score from the AHA, used to focus on just ASCVD. Now there's a heart failure risk component to it. But I think our mindset is still typically, you think about heart failure when somebody has their first episode and then manage it from there. But yeah, this idea of sort of combining risk factors, what we can learn from chamber sizes on CT and others. Your thoughts on moving this earlier and what further clinical trials do we need?
Yeah, it's a great question. I mean, I was taught many, many years ago that the left atrium is the SED rate for the cardiologist. So when you see left atrial enlargement, whether it's by a CT scan or, an echocardiogram or by an ultrasound that happens to be done point of care in the emergency department, that identifies already a patient who's at risk for further clinical progression. And that obligates us to go a little bit deeper. And so we've heard it many times today that we have to think about things from a pathophysiologic basis. What causes the left atrium to enlarge? It's usually higher left ventricular end diastolic pressures or a mitral valve that is leaking. So even in asymptomatic patients, it's telling us that there is already structural remodeling. And the first manifestation of it may be that left atrium. The downstream consequences of that, it can go down a couple different pathways. It can certainly go down a heart failure pathway. If I'm at elevated ventricular and atrial filling pressures, it does not take much more effort than to begin to develop shortness of breath as pulmonary pressures begin to rise. But the other thing that can happen is you can go down electrical pathway, and Dr. Reddy mentioned this. You get atrial remodeling, and that leads to electrical remodeling and atrial fibrillation, and then consequently stroke. So we do not yet have enough information to act solely on an elevated or an enlarged left atrium. But we do have evidence to say that if you have elevated natriuretic peptides, as an example of someone who has elevated filling pressures and ventricular strain, ventricular wall strain, then that's an indication to begin treatment. That's an indication to begin treatment with a RAS antagonist, and we have data going all the way back from the SOLVE trials that showed that solved prevention with the introduction of an ACE inhibitor can forestall and delay the onset of incident heart failure, and can also improve survival in patients who do develop symptomatic heart failure. What's really tantalizing is to think about the SGLT2 inhibitors, class of drugs that we haven't talked about today. But these cardiometabolic drugs are having profound effects, almost immediate effects on outcomes. We can begin to see improvement in cardiovascular event rates within 2 to 4 weeks of starting an SGLT2 inhibitor. And it makes sense then to think that these benefits extend not only to heart failure, but also to atherosclerotic events. So I'm a big proponent of starting them, but I will strike the note of caution that Dr. Reddy shared with us, which is that we do need clinical trials. And we do need clinical trials before we can advocate doing it. I think the direction and my bias is that they will be helpful, but we need to prove it.
Yeah, I wanted to ask Dr. Ahmadi to follow up on that. I mean, one concept, because one of the challenges around prevention is the clinical trials often get funded when there's a new drug or a new intervention that's associated with it, which has always been a challenge for prevention. But, you know, is a concept that people with a positive coronary calcium score or of a certain level, they get randomized to an SGLT2 inhibitor, a GLP-1, to really, you know, give more precise benefit. What are your thoughts on how do we evaluate these new drugs in combination with early disease detection?
Thank you. Not sure about the SGLT2, but I think I take it one step back. And I think what we are seeing here in this conference and in this realm of literature is a little bit of a shift in philosophy. And I think the shift in philosophy that we are all talking about is that we are going away from guesstimation to actually seeing early disease, specifically with ASCVD, specifically with coronary disease. The reason that we practice what we practice is very historical. And I think what we are really seeing now is that, to me, instead of actually thinking and completely focusing on blood markers, which are very important, and I'm not saying we shouldn't do that, coronary disease is at coronaries. The lipid particles that are actually in the vessels of the heart are the ones that cause problem, not the ones that are in the blood. If there is a relationship that is one-to-one from the blood to the heart vessel, great, but the relationship is not one-to-one. It's much more complex. So we see this in more of a sub-analysis of clinical trials. For example, you look at the Scott Hart trial, and you look at the patients that have non-cardiac symptoms. In 5 years, they have actually MI benefit, just by detection of the very beginning of their calcification and starting on statin treatment. They calculate the number for the NNT of the statin treatment in that MI prevention, and it becomes 3. And people are like, what are you talking about? Statin cannot have NNT of 3. And the answer to that is that it's not a statin of NNT. It's not an NNT of the statin. This is a number needed to treat out a different philosophy. You're guesstimating in one group and just putting it based on ASCVD risk score, which is important. And in the other group, you see the disease. The moment that you see the disease, you treat it. If you don't see the disease, you're not that committal. If the person comes with a muscle pain, you're like, okay, fine, try your other method. But if there is a disease, you're committed to it. So going back to your question about all of these drugs, I think what is very exciting is a new philosophy. And I think there are companies and there is industry that like this philosophy. And I think what really comes to it as an added bonus is this invention of AI. And I think what we are seeing in image and in CT is one thing, that what my eyes and my brain can comprehend, but in a deep learning model, for example, how to relate the calcification and the aortic valve that Dr. Sharma was talking about with an echocardiography, I'm sure in 10 years, AI will look at the CT and can predict the Vmax. And And I think the industry that is sponsoring that would be very much supportive of sponsoring the trial and the practical implication.
Dr. Nagavi has.
We came here for one big question, and that's the question that Dr. Maron asked Dr. Harrington, and that's the evidence. Because if we don't have the evidence, right, and now on the piggyback of that is the slide that I asked if you could bring back that slide. We have a 35, 37 million population. Could you please bring that slide? Okay, great. So the left side, this is a little outdated, but look at it, it's close to 40 million that qualify as part of intermediate risk that would fall under 2019-18 guidelines to get coronary calcium scan. On the right side is the lung cancer population that increased a little bit, close to now 10 to 15 million. What we're here, again, trailblazer, we're trying to open a new pathway, is that we apply a low dose to the entire population. We don't have evidence to subject the upper third of the lung to radiation. So that's one problem. The second problem is what comes downstream, what happens to those people that are found to have nodules or other pathology, intervention comes out. So if you could please help us from this collection of gray matters, we come to some level of direction of, so I asked David and Claudia before our meetings. David said, that 1/3, that extra radiation is equal to one at chest X-ray. Let's just prove that and demonstrate, model, and so on. We already have Fleischner algorithms of what to do with fine. Why do we have to launch a new trial for this? So if you could please elaborate.
So I'm going to make an assumption that this is a room of believers, and we need evidence for payers to pay. Who's going to pay for all those scans?
Whoever is paying now for downstream costs.
Yeah, maybe we can get one of the presidential candidates to promise to do it.
So we have a Medicare hearing coming up. This, whatever you guys come up with, we had 4 hearings. This is our 5th. This one is bigger because we're talking about something really large.
Yeah.
So any thoughts?
It's the question I was going to ask Dr. Ahmadi is, you showed, with the take-home point I got from your presentation, was that most of the events are occurring in low-risk people. The radiologists and pulmonologists in the room, they're seeing the high-risk people. So, yeah, we could start with incidental, but we're missing, and sorry using the term incidental, I don't know what else to call it, the bystander findings. Where do we go to find all those low-risk people? They're out in the population. We need population screening.
But I mean, let me maybe interject here a little bit. I mean, when we say, I was looking at your paradigm, and we've been discussing this for a very long time, with Fuster and Moore, and et cetera. You will find the plaque, but it does not mean that this is actually going to cause a disease. I mean, it's really, we never found that one-to-one correlation. It's a burden. It's the whole aspect burden. So maybe you can elaborate a little bit.
I would say this way: if you don't have a plaque, you're not at the immediate risk of MI, not actually type 1 MI. If you do have a plaque, it's kind of like a soccer game that is started and the other team is playing. If you're not playing against them, you may get scored a goal. But what is important is I had a slide that I showed detection of plaque, starting of a treatment, progression of a plaque, treatment intensification. And what we see right now, for example, there is this new paper came up, relatively new, in Lancet called Orphan Trial, that for those of you who are not familiar with this, is a score of inflammation around the vessel. It's called the FAI score. And what they showed is a tremendous detection rate. When you have this inflammation in your vessels that is not one-to-one related to a systemic inflammation, with an event rate if he had non-obstructive plaque 2 years prior to that. So point is, yes, the plaque itself doesn't mean events, but there are a bunch of other things, as you mentioned, biomarkers and other things and inflammation that can increase that probability and get us to intensify.
Maybe two quick comments. I mean, it's a question of really trying to figure out probability. I mean, that's very important, is to be able to do that. The second aspect, related to what you said about phi, which is that inflammation pericoronary, that's the same idea also with high sensitivity CRP. It is not a marker of exact inflammation. It could be related to this. It may be an integrator of this. And that's what we really have to try to get a little bit more detail.
All right.
Yeah.
And I think another, paradigm that has to change is we need to, think about staging of atherosclerosis, like how we stage heart failure. And, the prevent risk score has made some progress in at least staging cardiometabolic disease. So that's a step in the right direction. And I don't know, David, if you want to say a little bit about, the staging paper that is in development.
It's coming in the next few weeks.
I would. Yeah.
It's coming out in a publication. Yeah.
But I would say to Mort's question around when you're talking to agencies and how to get this used more, the guidelines use coronary calcium for, not just a black and white broad screening. It's much more to give you an athero burden to very directly guide therapy in the patient sitting in front of you. And a chunk will have a score of 0, and then the guidelines align coronary calcium score burden with degree of LDL lowering. So I think presenting it as not just a sort of broad yes or no, but it helps refine, optimize, personalize, and will tell some people don't need to go on therapy and others who need to be more on intensive therapy.
That don't need. So Dr. Fuster and I went straight to Maryland, to CMS, and sat down in front of the director of coverage. And, with his way of talking, he was saying, you have to also look at this CAC0, the CAC0 population, unburdened, unnecessary treatment that you have. Currently, you're paying for it. You're already paying for it. So if you can undo a significant investment that you're doing here and direct it to those who have CAC over 100 and high risk, we're not asking you to cuff out more money to the system. We're asking you to shift investment in primary prevention guided by imaging. So that's where we left it, and lower the cost if we do it properly. Now, in the same image, we now are showing with AI a bunch of other things that can predict heart failure, because we know calcium score sucks at predicting heart failure or atrial fibrillation, and possibly some of these markers of fat-related linked to inflammation. So, this was their dream. Claudia and David started this. They published this. I wasn't even collaborating with them when they published this. But now this dream is really close to reality with AI and without adding cost. So, but as experts, we have to define the downstream. Because if you put this on, as you know, in Pernuvo or some of the body MRI, people go get the MRI, and a majority of them have something. And if there is no well thought out plan on what to do with the downstream findings, causing anxiety, causing unnecessary interventions, and so on, we wouldn't do our job as people who want to improve healthcare. We're just making it probably worse. So if you could please elaborate on that with our panel. So two sides, the extra burden of radiation and then the downstream intervention that it causes for, I don't like his incidental finding reference, but opportunity finding, whatever. How do we see that coming together?
Well, it could take a while to truly respond. I would say that if we did dual screening. So if we're screening for lung cancer or other lung diseases, at the same time that we're screening for cardiovascular disease, that we, number one, make it more attractive to those people who should be screened, who are not being screened, so that they can get, for example, a coronary calcium score, which is typically only ordered for people at higher socioeconomic or higher education levels. So it would open it up to more marginalized populations who are not taking advantage of lung cancer screening, which is generally paid for. So that is one way to really open things up. But I don't know anything. Do you have some intelligent response to what Dr. Nagavi said? Yeah. Does somebody on the panel, would someone on the panel? Yes, Dr. Shemesh.
I think that all the think of imaging, early imaging of atherosclerosis, it's not by itself, it goes by the clinical picture. Who is the patient? And if you talk about downstream, you are not doing it only just because he has a calcium score of thousands. You are looking at the clinical presentation. Some of them are doing very well, and the others, if there are some chest pain presentation or what. So what I'm trying to say, that if you put and if you use the calcium score as one more information, very important information to your clinical patient. Who is the patient? What are the other diseases that he have? What are the risk factor that he has? There are maybe 13 of them. And then if you took all together, then you reduce the number to treat. You treat only those with the high risk and the MESA risk and the PCA risk, that algorithms that use the clinical picture with the calcium score gives you the answer. And you have a numeric answer, less than 5%, you don't have to treat. And above 7.5% should you to treat. And above 20%, you have to put all your effort and to treat there. So for the moment, all the things of soft plaque and all this inflammation, this is for the future. But when we are going home, the take-home messages is the calcium score, because it is well documented and you can use it. And the way to use it is to adapt it to the clinical presentation of your patient. It's not something, oh, I found calcium score, what to do. The question is the clinical presentation of the patient.
Yeah, and if I could also comment briefly that, with respect to the actually downstream tests in question, at least with the Eisner study, and I believe also with Scott Hart, right, there was no increase in downstream testing. So I think that's a very important point. And then lastly, one thing that we haven't touched on, and maybe Roxana or someone might want to comment on this too, is there's a huge opportunity also with actually mammograms, which are, because, you're able to detect, actually breast arterial calcification that has been shown to be associated with increased cardiovascular risk, and perhaps those women can then be further evaluated for their cardiac risk.
Thank you for bringing that up. And I think it's the power of AI again, kind of in play with looking at, and especially understanding how we're underdiagnosing, undertreating, and underappreciating cardiovascular disease in women. And the very popular and well adhered to screening for breast cancer in women allows you the opportunity to evaluate for breast calcification and its relationship to coronary calcification and cardiovascular disease. And that's work that's being done, but we still need millions and millions more data points to really prove that. But I believe this is a tremendous opportunity for this interdisciplinary imaging AI work and deep learning for us to to not speak in silos. And I think this is what this Congress is all about, is exchanging information with each other and finding opportunities when a patient is, it's what I often think about is if you're bringing the patient in, they're losing their entire day, you're doing a screening, imaging that their companies are paying for, then use every opportunity to at least get as much information out of this as possible. So I think it's an opportunity.
Yeah, I have one key point in the book where I say if you've had a chest CT, a mammogram, or a retinal image, and a disclosure, I work for help an AI company analyzing retinal images, but make sure they're reviewed for seeing coronary disease, breast artery calcification, or hypertensive diabetic retinopathy as increased risk. So, David, yes.
Yeah, I have a comment or two. First, in line with what Roxana, in terms of sort of siloing, we've done 46 conferences. We have never had a cardiology panel or discussion like this. This was absolutely spectacular. And I think this is really, as I said, this is going to be the inflection point where we're really going to see the integration of cardiology and into the lung screening and vice versa, and a much more holistic approach. So I am delighted with this panel discussion. The second piece of this, because I'm getting texts from China right now from my former fellow who is watching this very intently, who did work with us on the aortic stenosis. And, it's this kind of thing. We find a fair amount of, we developed an ordinal score for aortic stenosis. And she just reminded me that severe aortic stenosis with our ordinal score was 0.2%, but moderate aortic stenosis, according almost 2%. It's an enormous number. How many people do we think, now I don't know yet, I have to check because it's really important for us to do this, are acting on any of this information. We know, for example, we did go back and look at, for example, we report emphysema on all our scans. We went back and ultimately checked how many people knew they had emphysema. It doesn't get disseminated. Different people, and I suspect when we report all these cardiac findings, nobody's looking at them. I report severe aortic stenosis. I doubt that the majority of them are working it up. So again, it's almost another level of siloing that we have to figure out how to get this information out.
Maybe my chart is going to change this, because now these people are seeing everything and asking about every question. So I think my chart is a very big step forward.
So I think it looks like we have about 7 minutes left. Sounds like, why don't we hear from Claudia? And I know we've been delinquent about having the audience ask a few questions, but Claudia, go ahead.
So I just want to say or bring out what you said, that talking to the patient is really very important. And that communication, and we need to jointly do that more so that we communicate.
But we're not talking to our patients anymore. We're typing on computers. We're not using our stethoscope. We're not sitting at eye level. We're not asking the patient, what's going on in your life? Tell me about your stress. That's why I was late, because I literally, this is what I do. I spend a lot of time with patients because I believe that that is the opportunity for you to actually intervene and let that patient feel like someone cares about me. I need to figure out how to care for myself.
So let's say it for women. I called patients because I would call the referring physician. I'd say, do you want to talk to the patient, or do you want me to talk to? And in New York City, they said, oh, you talk to the patient. And I talked to them about and showed them their CT scan. And they would call me and say, thank you so much. When I walked across the street and I started to light my cigarette, I thought of that CT scan that you showed me. And it was that there's tremendous information. We talk about AI and so on, but it's that communication, facilitating the communication with the patient, and here's something that you need to think about. And that's what I think Mort is trying to do.
But our plan is to make it, in fact, the patient gets it faster than the radiologist. That much, that fast. AI does it. It says pending radiologist approval, but it's already in their app before they get home.
that's the goal. That's what we hope to get ARPA-H to buy into it. But we have this big question in front of us, whether we have the evidence to improve, to implement it. Claudia's suggestions and our team is that we go to ARPA-H and say, we're going to run this with consent. So we just disclose that this is a research. We're going to collect data, maybe 500,000 patients or 1 million patients, but we implemented the research project. Please go ahead around the room.
Yeah, if you maybe pass behind you. Yeah. Yes.
Hi.
And others raise your hand as you're. Yeah.
Just quick point. I'm a radiologist and I read a lot of these screening CTs. I think something that we're not explicitly saying, but we should, and something that's already happening on all of these screening CTs is a very understandable recommendation at the end of every CAT scan, which says, like for the calcium score, we say your ordinal calcium score is 8. That means that you're at risk for coronary artery disease and you should see a cardiologist to address your risk factors, right? It's a standard macro that comes on all of our CTs. Similarly, we could say, I say the same thing for aortic valve calcification. Especially in a younger patient, I might say this may represent a bicuspid aortic valve. I clearly say, go see a cardiologist and get further imaging. So I think very often radiologists say things that aren't understood by the patient or the referring doctor, for instance, which is that there's moderate aortic valve calcifications, period. Well, what does that mean? Right? That's, I think, a big step forward.
Yes.
Fred Grannis, as a retired thoracic surgeon, this was a spectacular review of adult cardiac disease. And congratulations to everybody. One question I didn't hear is the proof that calcium and plaque are equal to each other. And I would think that there would be a time when plaques begin to become calcified. But what evidence is there to link calcium to plaques?
So we do actually have a little bit more on this at a session tomorrow morning. And others can chime in.
I have an answer.
Yes, go.
Calcification of the plaque is some kind of healing. And Peter Libby shows very nicely that high dosage of statin of 80 milligram, when he compared it to 40 milligram in IVUS, he showed that this is increased the calcification and reduced the acute event. So what we believe now, for your question, what is the calcium is doing there? It's some kind of healing, like every chronic inflammatory disease that we have, like tuberculoma, like echinococcus, like in the shoulder. You see always calcification in an area of chronic, long-standing inflammation. And we do believe, and a lot of researchers think so, that calcification is stabilization and some kind of healing of the plaque.
Yeah, but I think we also know that it is a powerful marker of the overall burden of atherosclerosis from numerous angiographic comparison studies done over the last 30 years, right? And if you have a high calcium score, there's a great probability that somewhere, not at a site of coronary calcium necessarily, but somewhere you are likely to have an obstructive, an obstructive plaque.
And just for clarification, definitely patient handout, yes. I would bet that Dr. Wong has it. I just want to make one clarifying remark. The plaque doesn't begin as calcified. It begins as non-calcified plaque. And over time, it becomes calcified. And it's really nice that it gets calcified so that we can see it non-invasively and get an indication. But there are people walking out there who have atherosclerosis that don't have any calcification. They have non-calcified plaque. With aggressive treatment, the non-calcified plaque volume diminishes and the calcified plaque increases and increases in density. Doctor, really quick, we have 59 seconds.
To go back to Dr. Nagami's point as to what next step is needed, I think one of the missing points that we have in this is not just to screen, but what to do with the information of screen in terms of treatment. And I think within the community of cardiology, we don't have a unifying answer to that. One of the things that I try to mention is that diseases start with plaque, ends with plaque rupture, in between is progression. The reason that we have a secondary prevention guidelines is that we know that around LDL of 60 or 70, we can stop progression. But I'm not entirely sure if all the cardiologists, if see a calcium score of 1, they bring the LDL less than 70. If we do that, we actually see event reduction. If we see event reduction, we have NNTs, we have cost calculations. We've had that in a 2,000 patient population in a practice that I was involved, and the cost of MI prevention will be under $20,000 in a 7-year follow-up. And I think that's in a larger scale what we really need. But currently there is a little bit of a confusion as to what to do with these numbers.
Yeah. That's what we are proposing to ARPA-H, that find the disease with atherosclerosis, positive, negative, now with, you know, with type 1, 2, or 5, and then do intervention and put a very clear boundary. No additional tests is needed. Exactly. So don't spend another $1,000 on a nuclear or echo. Get this patient on a cheap statin treatment, you know, $20, you know, $30 a year. We have that and be able to improve outcomes. So I think this is the hope we had for this session to bring up. We knew that we could not finish it. Claudia said, don't hold on your expectation high, you will have a, but we are going, as I showed you, this reshaped working group. We're going to communicate with you, all of you in this panel, for a write-up, just like we did with our first SHAPE task force report. This would be the first of long and hard. So it's really exciting. 20 years ago, I did that with SHAPE, and we're going to do it.
And nothing changed since.
It's changed. Yes, redefining your.
SHAPE really reshaped many, many things. I'm going to say a lot has changed since SHAPE.
So
not clinically.
We're missing in here. He termed reshape based on this, and I honor that, and we're going to communicate with you.
Shape up.
For a right.
Get in shape. Get in shape.
Get in shape.
Yes.
Shape up.
So this was the introduction of cardiology to the lung community. The next session will be the lung community introducing our issues to the cardiac community. We have a pretty tall order to meet the quality that we saw today. So I just want to thank the panelists and the moderators for what I think was just a spectacular set.